Hello students, so now let's discuss about protein synthesis inhibitor. So in this section of antimicrobial, first we will understand that how protein synthesis occurs in a bacteria and on which step these antimicrobials they will act, and then we will discuss variety of antimicrobial drugs in this section. So first question comes in our mind, sir, how protein synthesis occur? We all know protein is synthesized from translation of mRNA. Now on this mRNA, ribosomes, they will come and attach, which will produce protein synthesis. So let's see in a bacteria how protein synthesis occur. So remember one point, that ribosomes in bacteria, they are 70S type of ribosome. And this 70S type of ribosomes in bacteria, they contain two subunits. One bigger subunit of ribosome is 50S and the smaller subunit is 30S. On this 30S ribosome, there is some site known as A site. A means attachment site, where amino acids will come and attach. And on 50S ribosome, there is a site known as P site. P site, I will be telling you, it will form peptide bonds which will lead to production of proteins. So let's see how protein synthesis occurs. First of all, we know we need amino acids. So this amino acids, they will come and attach on A site. This is the first step. So just imagine this is an amino acid and it is attached to tRNA, because tRNA or transfer RNA will bring or transfer this amino acid to A site or attachment site. Now after this first step has occurred, this amino acid will change its location. From A site, it will translocate to P site. Now what will happen? A site has become free. A different amino acid will come depending upon the mRNA codon. Now can we say both P site and A site have one amino acid? Now why P site got its name P? Because it has one enzyme, that is peptidyl transferase enzyme. So this peptidyl transferase enzyme will make peptide bonds between these two amino acids. And this step will continue and it will lead to formation of a big protein. So now after this peptidyl transferase, we have learned three steps: attachment, translocation and peptide bond formation. Keeping this thing in mind, let's start now how antimicrobial drug they will reduce this protein synthesis. So we discussed the first step was tRNA attachment, which is bringing amino acid and it is attaching to 30S subunit, A site, attachment site. This first step is blocked by two drugs, tetracycline and tigecycline. How we can remember? Tetracycline and tigecycline, they will inhibit tRNA attachment to 30S subunit, attachment site, A site. Now the next step was translocation. So this translocation is inhibited by three groups of antimicrobial, that is macrolides, in which we will discuss erythromycin, azithromycin. Second drug is clindamycin and the third drug is streptogrammin. After translocation, the third step was peptide bond formation by peptidyl transferase enzyme, and this third step is blocked by chloramphenicol. Can we say chloramphenicol? It will come and attach to 50S ribosome, block P site, inhibits peptidyl transferase enzyme. Now there are two more antibiotics. The first is a very unique antimicrobial drug, linezolid. Linezolid attaches to a very unique site of 50S. It attaches to 23S subunit of 50S ribosome and it inhibits the attachment of methionine tRNA. Sir, what is the importance of methionine tRNA? We all know in any protein synthesis, the first amino acid which is always required is methionine. So it causes initiation or start of protein synthesis. So if linezolid binding to 23S subunit of 50S ribosome inhibits the attachment of methionine, can we say it will inhibit initiation of protein synthesis? Now, it's very unique. Let's talk about the last antimicrobial, which is aminoglycosides. Aminoglycosides, they will also attach on 30S subunit and they have variety of actions. We can remember a mnemonic IMP, important. I for they also inhibit initiation of protein synthesis. They produce misreading of mRNA. Misreading means a different type or a defective amino acid will attach. And lastly, they inhibit polysome formation. Sir, what is polysome? Polysome means assembly of mRNA and ribosome. This is known as polysome. When ribosome attach, it forms polysome with mRNA. So can we say ribosomes will not attach on mRNA? So this is a beautiful story which we all have to remember. Keeping this thing in mind, now let's answer certain questions. So can you answer which antimicrobials were acting on smaller subunit, that is 30S? Remember only three. ATT. A for aminoglycosides. They were inhibiting multiple steps. T for tetracycline. And last T was a brother of tetracycline, that is tigecycline. So this is a question which you have to remember. Apart from these ATT, all other drugs, they are acting on 50S ribosome. So that we will make a list. First is MCQ. M for macrolides. So macrolides, azithromycin, which we are going to discuss. C for clindamycin. Q for quinpristine with dalfopristine. One question will come in your mind, sir, you have not taught about this drug. We have not mentioned. Remember this combination of quinpristine and dalfopristine. It is known as streptogramin. So we discussed streptogramin. Streptogramin is a mixture of quinpristine and dalfopristine in 30:70. So can we say these MCQ, they were inhibiting translocation of amino acid by acting on 50S. They all three have same mechanism of action. So don't you think, beta, if a bacteria becomes resistant to macrolide, don't you think clindamycin and streptogramin, they also have same mechanism of action? The bacteria will also become resistant to other two antibiotics. So a question comes, which three antibiotics they show cross resistance? Cross resistance means if a bacteria becomes resistant to any one of them, very high chances other two antibiotics will also become resistant. C for chloramphenicol, which was inhibiting peptidyl transferase by acting on 50S ribosome T site. And lastly, unique drug linezolid. Linezolid was acting on 23S subunit of 50S ribosome. So these are the drugs. Now among this big list, which drug are bactericidal? Only two drugs are bactericidal, A and S. A for aminoglycosides and S stands for streptogramins. Apart from these two drugs, rest all other protein synthesis inhibitor are bacteriostatic. Now the next question is, sir, there are variety of drug. What is their spectrum of action? So they are divided into three types: broad spectrum, intermediate spectrum, and narrow spectrum drug. Broad means they are effective against all types of bacteria. So among them we have four drug broad spectrum CTCT. C for chloramphenicol, T for tetracycline, C for clindamycin, and last T for tigecycline. Sir, which drug is intermediate or middle? Middle means intermediate. Some bacteria are killed, some are not killed. M for middle, M for macrolides, intermediate acting. While rest all other drugs are narrow spectrum drug. Narrow spectrum means they will only kill very few types of bacteria. We have three drugs: aminoglycoside, linezolid, and streptogramin. Very commonly asked question that aminoglycoside is a narrow spectrum drug. Remember, it will only kill aerobic bacteria. I will be telling you anaerobic bacteria are not killed with aminoglycoside. Similarly, linezolid and streptogrammin, they are only effective against gram-positive bacteria. They are not effective against gram-negative bacteria. Hence, they are very narrow-spectrum drug. So, keeping this list in our mind, let's start with these drugs in this similar order. So, we will first start with a beautiful drug, chloramphenicol. So, let's recall what was the mechanism of action of chloramphenicol. Chloramphenicol inhibit peptidyl transferase enzyme. And this peptidyl transferase means P site, it was located on 50S ribosome. So it acts on 50S subunit of ribosome and inhibit peptidyl transferase enzyme. Next point, many bacteria are developing resistance to chloramphenicol. It is one of the oldest drugs we have. The cause of resistance is enzymatic degradation inside the bacteria. What does it mean? In simple word, when chloramphenicol enters into a bacteria, suppose this is a bacteria, chloramphenicol is entering, bacteria produces certain enzymes and these enzymes degrade chloramphenicol. And one enzyme, you should remember, the name of the enzyme is CAT enzyme. CAT stands for chloramphenicol acetyl transferase enzyme. So this leads to resistance among bacteria. Now, how chloramphenicol is given? What is the route? Although it is a very old drug, so don't you think it is given by almost all route? It is given orally. It is given as an IV drug. It is also given as a topical eye and ear drops for the treatment of local eye and ear infection. So let's see what are the uses and side effects of chloramphenicol. For that, just remember 4 B's. First B is chloramphenicol. It is a broad spectrum drug. That means it kills all type of bacteria. Gram positive, gram negative, anaerobic, atypical which lacks cell wall. Its brain entry is very good. It very good enters into brain. So if it is entering into a brain in a very good amount, can we say it's a broad spectrum drug? Entry into brain is very good. Don't you think if a patient of meningitis comes to you and right now you don't know which bacteria has caused this meningitis, don't you think you need a drug which should be a broad spectrum drug, which should kill all types of bacteria and which has a very good entry into the brain? That is why chloramphenicol, it is very much given for empirical. Empirical means when we don't know which bacteria has caused, empirical treatment of meningitis. So now let's talk about the side effects of chloramphenicol. The dangerous side effect of chloramphenicol is it causes bone marrow suppression. Bone marrow suppression can be written as aplastic anemia. Now this aplastic anemia shows 2 patterns with chloramphenicol. First type, it can cause dose dependent. Aplastic anemia, dose dependent means if we give higher dose, then bone marrow suppression will happen. So can we say this type of bone marrow suppression is preventable in nature? Why it is preventable? Because if we will reduce the dose, it will automatically become normal. Or can we say it is a reversible type? Because by reducing the dose, we can prevent this bone marrow suppression. But in some people, this chloramphenicol can also cause dose-independent bone marrow suppression. That means it can occur at any dose. And this type of reaction is known as idiosyncratic reaction. Idiosyncratic means we don't know at which dose it is occurring and it is not preventable. It is irreversible and it is permanent. So we have to do bone marrow transplant. Because of this risk of bone marrow suppression, which can be permanent, we less commonly prefer to use chloramphenicol nowadays. Now, the last side effect is very important. Chloramphenicol should not be given in babies. In babies, chloramphenicol is contraindicated. Why? Because chloramphenicol in babies causes gray baby syndrome. So, gray baby syndrome is a side effect of chloramphenicol which is seen in newborn babies or neonates. Because of the risk of gray baby syndrome, chloramphenicol is absolutely contraindicated in neonate. So one question comes in our mind, sir, what happens in gray baby syndrome? Let's understand that part. Remember, in our mitochondria, inside the cell, we have mitochondria. Inside the mitochondria, we have certain enzymes. So these enzymes we have discussed in general pharma, that is CYP enzyme, cytochrome P enzyme, and glucuronide enzyme. Glucuronide is UDP-GT enzyme, that is uridine diphosphate glucuronide transferase. These enzymes are responsible for degradation of toxins, degradation of other drugs. Chloramphenicol is a very strong inhibitor of these mitochondrial enzymes. Now, don't you think if mitochondria will stop working, what will happen? Your cell cannot make ATP. Your cell cannot utilize oxygen. And all the cells, all the organs of the body will die because of hypoxia. So, because of this mitochondrial inhibition, this small child will have multiple organ damage. And because of multiple organ damage, the child may go into shock. And the skin of the child will become cyanosed or grey. So it's a very old disease. The skin of the child will become cyanosed or grey. We used to call it as grey baby syndrome. That is why don't give chloramphenicol in a newborn child or a neonate, because chloramphenicol causes grey baby syndrome. So this is the first antimicrobial. Now let's come to the second one. Second one we have is a group, tetracycline group. Remember one thing, any drug in tetracycline group will end with the word cycline. So if I say doxycycline, minocycline, they all will be under tetracycline group. Recall what was the mechanism of action of tetracycline. Tetracycline, they bind to 30S subunit of ribosome and they inhibit attachment of tRNA, and tRNA contains amino acid. So amino acid tRNA to which site? To A site. A site means attachment site. Now what is the cause of resistance to tetracycline? Many bacteria, it's again a very old drug, so many bacteria are becoming resistant. The cause of resistance is very unique. When this tetracycline enters into this bacteria holds this tetracycline and again throws back. So the cause of resistance of tetracycline is efflux out of a bacteria. And to throw this tetracycline out, bacteria makes a special protein. This special protein is P-glycoprotein. So bacteria makes P-glycoprotein which causes efflux of this tetracycline. Remember, this efflux out of a bacteria is cause of a resistance to tetracycline and its brother tigecycline. Remember, tigecycline is a new drug, but right now there is less risk of resistance to tigecycline because some bacteria are only making this type of resistance mechanism. Most of the bacteria are still sensitive to tigecycline. So let's talk about first tetracycline group. So in tetracycline, the older drug which we made, they were named as tetracycline. So the first drug we made was tetracycline. So we named the group as tetracycline group. Then we made other drug, chlortetracycline, oxytetracycline. They are nothing. They are just the modification of tetracycline. And they are very old drug. We put it under group 1. Then we made newer drug, After that, we made dimeclocycline. It is under group 2. And lastly, we made two very important drugs which we are using nowadays very commonly, minocycline and doxycycline. These are the group 3 or newer tetracycline. So let's see their uses. Let's talk about the first drug, tetracycline. Remember 2Ps where it is used, 1P, second P. First, it is used in peptic ulcer. And we know which bacteria causes peptic ulcer? Helicobacter pylori. Second, it is also given for prophylaxis or prevention of cholera. Again, cholera is a very old disease and old antibiotic is tetracycline. So prevention of cholera, we give tetracycline because cholera spreads in community. So we have to protect healthy people. But what is the treatment or drug of choice for the treatment of cholera? For treatment of cholera, we use the big brother of tetracycline, that is doxycycline. We give doxycycline. Next drug we have to remember is dimeclocycline. Now, dimeclocycline has a very unique property that it blocks ADH receptor on kidney. Now, any drug that blocks ADH receptor on kidney or nephron, what will happen? ADH will not able to act on kidney, antidiuretic hormone. Water will not be reabsorbed from urine back into the blood. All the water will be excreted out in urine. So the patient will have a symptom of polyuria, and this disease we have discussed very much in great detail in kidney. This side effect is known as nephrogenic because it is acting on kidney. ADH is not able to act. Diabetes insipidus. It is known as nephrogenic diabetes insipidus. So because it is blocking ADH receptor, can we give doxycycline when in our body we have excess of ADH hormone? So yes, doxycycline is given in the treatment of SIADH, which stands for syndrome of inappropriate ADH secretion, in which there is excess of ADH hormone in the body. Now, the two new drugs, minocycline and doxycycline in this group. Minocycline, just remember, it is given for the treatment of acne. So it's an oral drug given for the treatment of acne. And it is also given in the treatment of leprosy. Then we have doxycycline. The most important drug we have is doxycycline. With doxycycline, first we will write all the good points. Doxycycline among them is the longest acting drug, and doxycycline is the only tetracycline which is safe in renal disease patient. Because it is not excreted in urine, it is rather excreted in bile. Which tetracycline is safe in renal disease? That is doxycycline. Many times asked question. So most of the time, the most commonly used tetracycline is doxycycline. Let's see the uses of doxycycline, the most famous drug. So let's talk about the uses of doxycycline. Let's make a mnemonic. Less RBC in blood, produce microcytic anemia. L4. Doxycycline is the drug of choice for leptospirosis. So in leptospirosis, it is given both for the treatment of leptospirosis and for prevention of leptospirosis. R4, it is the drug of choice for rickettsial infection. It's a very frequently asked question. B for Borrelia infection. I will be telling you in the treatment of Borrelia and all other infection in great detail. Borrelia causes Lyme's disease, relapsing fever. Drug of choice is doxycycline. It is given for chlamydia and cholera. Drug of choice. Now sometimes we inject this doxycycline into pleural space. We know there are two pleural membranes. The outer one is parietal pleura. The inner one, which is attached to the lungs, is visceral pleura. Sometimes between this two pleural membrane, air deposits, and we call this disease, dangerous disease, as pneumothorax, and it can lead to compression of lungs. So sometimes these two pleural membrane must be fused together. This fusion of pleural membrane is known as pleurodesis. And pleurodesis is done for the treatment of pneumothorax. We inject doxycycline between two pleura. It will lead to fibrosis and two pleural membrane they stick together. Now, other drugs which can be given for pleurodesis, yes, apart from doxycycline, we can also inject talc. We can also inject iodine. They also cause fibrosis or sticking of pleura among each other. B4, it is also given for brucellosis as a drug of choice. Plague prophylaxis. Plague, a very old age disease. Now remember, for prevention of plague, we give doxycycline. But sir, which drug we give for the treatment of plague? For treatment of plague, we give injections of streptomycin. Prevention, doxy. Treatment, streptomycin. Now it is also given for Mycoplasma hominis, and lastly, it is also given for anthrax. Remember, I have written out a word here, Mycoplasma hominis. Remember, doxycycline is not effective in Mycoplasma pneumoniae, because Mycoplasma pneumoniae is a bigger problem and it causes community-acquired pneumonias. So now let's talk about the adverse effects of tetracycline. So remember, tetracyclines, they love calcium. They chelate or bind with calcium inside the body, wherever the calcium is present. Because of this reason, first point, that tetracyclines, they are absolutely contraindicated in pregnancy. Tetracyclines, they are absolutely contraindicated in children less than 8 years of age. We don't give tetracycline like doxycycline, minocycline. Why in pregnancy? Because in fetus, tetracyclines will lead to bone and cartilage defects in fetus. Bone cartilage, they contain lot of calcium. Now, why in children? First, very important point, what about teeth? Sir, it will lead to teeth damage. The teeth of a child will not erupt. So, don't you think it will lead to discoloration of teeth? It will lead to damage or mottling of teeth. And properly the teeth or the enamel, it will not get produced. Second point is, till 8 years of age, it will lead to stunting. Stunting means the height of that child will remain very dwarf. It will not increase. Because of this risk, we never give tetracycline in children and pregnancy. Last point, tetracyclines are contraindicated with milk containing foods like cheese, in India, ghee. So anything which is made from milk, don't give tetracycline along with those food. The reason is very simple. Milk containing food, they contain lot of calcium. And we give tetracycline with them. Tetracycline binds with calcium in GIT. Neither tetracycline will get absorbed, nor calcium will get absorbed. So avoid giving with milk containing foods like curd, paneer, cheese, etc. So keeping this thing in mind, so let's talk about adverse effect of tetracycline. So again, we can make a mnemonic, very rapid LFT. First is important, vestibulotoxic. They damage ear. And which tetracycline causes vestibular damage? We will write minocycline. Minocycline is a tetracycline which causes ear damage, permanent ear damage. They are contraindicated in renal failure. All tetracyclines are contraindicated in renal failure except, we just discussed, doxycycline. Doxycycline is renal safe. It can be given. Very important question. Now they have anti-anabolic effect. Now anti-anabolic means they will produce stunting. And this stunting will be seen in children. That is why we avoid them in children less than 8 years of age. Now they can cause photosensitivity on skin. Because they produce photosensitivity of skin, we never give tetracycline as our topical skin cream. Never give tetracycline as skin cream because of the risk of photosensitivity or skin damage. any other drug which I have told you causes photosensitivity? Avoid them as skin cream. Yes. Also, fluoroquinolones. Fluoroquinolones like ciprofloxacin, levofloxacin, they also produce photosensitivity, just like tetracycline. Don't give them as skin cream. Now, tetracycline, sometimes they can increase intracranial pressure. This increase in intracranial pressure due to tetracycline, we call it as pseudotumor cerebri. Why we call it as? Very simple reason. Most of the time, why intracranial pressure increases? Because some mass in the brain like tumors, tuberculosis infection. So it is mainly because of blockage of CSF flow. When CSF cannot flow properly, the pressure will increase. But in pseudotumor cerebri, it is not tumor. It is because of drugs. These drugs, they don't block CSF. So they rather increase the production of CSF. So here comes a question. Which drugs can produce pseudotumor cerebri? We can remember a mnemonic VOTE. One vitamin which causes pseudotumor cerebri is vitamin A. O for OCPs, that is oral contraceptive pills, and T for tetracyclines. So remember drugs causing pseudotumor cerebri. Now D for they can cause diabetes insipidus, that means they block ADH receptor, and this side effect was seen with which tetracycline? It was seen with demeclocycline. That is why it was given for the treatment of SIADH. Now tetracyclines are contraindicated in liver disease. And remember, all tetracyclines, including doxycycline. Now how we can remember this point? I have written one point that renal failure, all are contraindicated except doxy. But in liver failure, including doxycycline, don't give tetracycline. Now they have a very peculiar side effect of Fanconi syndrome. Now Fanconi syndrome is renal damage, especially damage to PCT of nephron. This damage of PCT of nephron, that is proximal convoluted cells of nephron, this peculiar side effect is seen with expired tetracycline. So there were many reports that expired tetracycline, they can cause renal damage, Fanconi syndrome. And lastly, the most important, we know that tetracycline chelate with calcium. Because of this reason, they can cause tooth damage. It's a very frequently asked question. So let's talk about certain newer tetracycline. The first drug we have is saricycline. Now how to remember saricycline? You can see S and A word is coming. So it is approved for S and A. It is given for the treatment of severe acne. So in the treatment of severe acne, just like minocycline, a new drug is saricycline. Then we have omadacycline. We can see omadacycline, MAD word is coming in this. So omadacycline, it is given for treatment of MAD. Now MAD stands for, it is effective in MRSA, methicillin resistant Staphylococcus aureus. It is given for abdominal infection. And lastly, D for, it is given for dermis. Dermis means skin and soft tissue infection. So again, it's a very broad spectrum drug given for variety of these MAD infection. So what is the use of eravacycline? Sir, same use. Eravacycline, same use. Sir, what about tigecycline? Sir, same use, MAD. So it's a very commonly asked question where tigecycline is used. Is it effective in MRSA? Sir, you will say, yes, sir, it is effective in MRSA. Now let's talk about a very important drug, very commonly used in our hospital nowadays, that is tigecycline. Now remember, tigecycline is ending with the word cycline, but in fact, it is not a tetracycline. Its group name is different. It is rather, its group name is glycyl cycline group. So it is under which group? Glycyl cycline group of antibiotic. Now, what was the mechanism of action of tigecycline? its mechanism of action was same like tetracycline. It was also attaching to 30S subunit, and it was also inhibiting the attachment of tRNA on A site. So let's talk about three very important points with tigecycline. We will write 3R. The first is tigecycline is a renal safe drug. That means it can be given in cases of renal failure. Which other drug was renal safe? Doxycycline. Now, resistance to tigecycline is less common as compared to tetracycline. But yes, it is slowly developing. So just recall what was the cause of resistance to tigecycline. So tigecycline, again, when it enters into the bacteria efflux out this tigecycline. So the cause of resistance was similar to tetracycline, but it is less common. Because the resistance is less common, right now, this tigecycline is a reserve drug. We don't use it commonly. It's a reserve drug for hospital-acquired infections. So, which hospital-acquired infection we will give? Tigecycline, you will say, sir, MRSA, abdominal infection, skin and soft tissue infection. So this is a new drug. Now let's talk about treatment of certain important infections. So the first is cholera. Cholera is caused by Vibrio cholerae, lot of diarrhea. Remember, what is the drug of choice for treatment of cholera? Treatment of cholera, we give doxycycline. For prevention, we give tetracycline. Now, we know one thing, that doxy and tetracyclines, they are contraindicated in pregnancy and they are contraindicated in children less than 8 years of age. So if a question comes, sir, what is the drug of choice for treatment and prevention of cholera in pregnancy and small children? In pregnancy and small children, both for treatment and prevention, the drug of choice is azithromycin. So cholera in pregnancy, cholera in children, give azithromycin. It is safe in pregnancy and children. So the next infection we have is chlamydia. Chlamydia, it can also cause one sexually transmitted disease, that is LGV, lymphogranuloma venerum. Plus chlamydia can cause community acquired pneumonia. Now, what is the treatment of chlamydial infection? We give the combination of doxycycline with azithromycin. Now remember, doxycycline, it is given 100 milligram twice a day for at least 5 days. What about azithromycin? Azithromycin for trachoma and LGV, I am telling, it is 1 gram single dose. So which drug for trachoma and LGV is given as a single dose treatment? You will say azithromycin. And if I'll ask you a question, trachoma in pregnancy, community acquired pneumonia in pregnancy, would you give doxycycline or azithromycin only? We will only give azithromycin. Now, very important infection, that is rickettsial infection. And you know, in rickettsia, certain species, they can lead to eschar formation. Again, what is the treatment? Such same treatment like chlamydia, give a combination of doxycycline with azithromycin. Their combination is better than single drug alone. So this is the treatment, very important for rickettsial infection. Let's talk about Borrelia infection. Borrelia has 2 species. One is Burgdorferi. Burgdorferi causes a disease known as Lyme's disease. And Borrelia recurrentis, recurrentis means again and again means relapsing fever. So what is the treatment? The drug of choice for Borrelia infection is doxycycline. But if this Borrelia is producing meningitis, in that case, we have to give penicillin injection. If we can give penicillin G, benzathine penicillin, amoxicillin, any type of penicillin we can give. What about leptospirosis? Again, the drug of choice for leptospirosis is doxycycline. But if there is meningitis, we have to add ceftriaxone injection. So this is the treatment of leptospirosis. Now let's talk about after tetracycline group, very important group, that is macrolide. Remember in macrolide how to identify them. These drugs will end with the word thromycin. Thromycin word will come. So the first is clarithromycin, azithromycin, roxithromycin, erythromycin. But one exception is there which we have to remember. It is not having thro word in it. The drug name is spiramycin. And just write one point with spiramycin. As we have discussed, spiramycin, it is the drug of choice for toxoplasma infection in pregnancy. So we have discussed in protozoa the special property of spiramycin was spiramycin concentrates in placenta. When it deposits in placenta, it will prevent the transmission of this toxoplasma from mother to fetus, because toxoplasma in fetus can be very dangerous because it inhibits placental transfer of toxoplasma. So let's come back to macrolide. What was their mechanism of action? We remember macrolides like erythromycin and azithromycin, they bind to 50S ribosome and they inhibit translocation of amino acid. So from A site to P site, amino acid will not translocate. So what is the cause of resistance to macrolide? Very logical, mutation in 50S ribosome of the bacteria. So if the ribosome becomes changed, can we say macrolide will not able to bind to these 50S ribosome? So let's see what are the drugs we have to remember. Remember the first four drugs, care, C-A-R-E, care, clarithromycin, azithromycin, roxithromycin, erythromycin. Remember all will have same uses. But we will write that clarithromycin among them, it is also given for the treatment of H. pylori infection. It is most effective macrolide for Helicobacter pylori for the treatment of peptic ulcer. Now recently we have developed a new drug, and that new drug is made in India drug. That new drug is nephithromycin. So nephithromycin is a new macrolide which was developed recently in India. So let's talk about, before coming to their uses, the three most commonly used macrolides are erythromycin, clarithromycin, and a very famous azithromycin. Let's compare these three together. Before comparison, remember one rule, that erythro is a very bad one. All the bad properties we will write with erythromycin, and all the good one we will write with azithromycin. Okay? And clarithro is in middle. So don't you think when you suffer from any infection, you also prefer to take azithromycin only? So keeping this thing in mind, if I'll ask you a question, which will have shortest duration of action? The shortest acting will be azithromycin. It is given 3 times a day, while azithromycin is the longest one, just given once or maximum twice a day. Now, which macrolide inhibits CYP enzyme, cytochrome P enzyme, and P-glycoprotein enzyme? Again, maximum inhibition is by erythromycin, least inhibition is by azithromycin. The importance is many drugs, they are degraded and removed out of the body by CYP enzymes. Don't you think if we combine erythromycin with other drug, it will increase toxicity of other drugs? So which drug will have maximum drug interaction? It is erythromycin. Azithro will have least drug interaction. So safe to be combined with other drug is again good drug, azithromycin. Now which drug causes QT prolongation on heart as a side effect which can be dangerous? Maximum risk of causing QT prolongation is by erythromycin and least risk is by azithromycin. Now the last side effect is very important, that is hypertrophic pyloric stenosis. So which drug causes hypertrophic pyloric stenosis in neonates? We will write it is again by erythromycin and clarithromycin. It is not seen with azithromycin. Because of this reason, we avoid giving erythromycin and clarithromycin in neonates because of the risk of hypertrophic pyloric stenosis. So which drug among three will be safe in neonate? It is safe in neonate, that is azithromycin is neonate safe. So keeping this thing in mind, let's talk about, sir, why we made macrolide. If you remember the previous story, tetracyclines, they were chelating with calcium. Very old drug. So don't you think because tetracyclines were chelating with calcium, they were absolutely contraindicated in pregnancy and children, we were not giving tetracycline. Macrolides, they are safe drugs in pregnancy and children. Because of this reason, nowadays uses of tetracyclines are now being overtaken by macrolides like azithromycin. So keeping this thing in mind, let's see the uses of macrolide, erythromycin, azithromycin like drugs. So uses of macrolide, let's make a mnemonic. 5C SLAP. First is they are the one of the drug of choice for community acquired pneumonia. So let's make a star and we will show why they are the drug of choice for community acquired pneumonia. Azithromycin, it is also the drug of choice for cholera in pregnancy and children. We just discussed. They are also the drug of choice for chancroid. Chancroid is a sexually transmitted disease caused by Haemophilus ducreyi. So sexually transmitted disease, azithromycin. They are also the drug of choice for diphtheria, Corynebacterium diphtheriae. And lastly, Campylobacter donovenosus, another type of sexually transmitted disease. Now, SLAB, they are given for variety of STD. Remember, any sexually transmitted disease come and you find an option of azithromycin, go with it. We will shortly discuss all STDs. Then, Legionella pneumonia, drug of choice is erythromycin and azithromycin. Remember, Legionella, it can cause community-acquired pneumonia. Any other bacteria which causes community-acquired pneumonia or atypical pneumonia, drug of choice for Mycoplasma pneumoniae is azithromycin, erythromycin, because it also causes community-acquired pneumonia. And lastly, small child with barking or whooping cough, which disease I am talking about, which can also lead to pneumonia, that is pertussis. Again, the drug of choice is erythro and azithromycin. So they are a very important drug. So let's first talk about the adverse effect of macrolides. Adverse effect of macrolide, remember a mnemonic, macro IQ. First M stands for they stimulate motilin receptors in GIT. Because they stimulate motilin receptors in GIT, they produce a side effect of hypertrophic pyloric stenosis. And because they stimulate motilin receptors, can we say erythromycin-like drug, they will increase GIT motility. Because they increase GIT motility, they can cause a side effect of diarrhea. So this effect is sometimes known as prokinetic effect. Pro means increasing GIT motility. A for they can cause allergy. C for they can cause cholestatic jaundice. Now this cholestatic jaundice is only seen with, not with all macrolide, it is only seen with erythromycin acetolate. So this acetolate salt of erythromycin causes cholestatic jaundice. That is why this acetolate salt we don't prefer to use. RO stands for they can cause reversible ototoxicity. I for they have immunosuppressive effect. They reduce the immunity of the body. Sir, how and why macrolides reduce immunity of the body? Remember, we have T lymphocytes. And in our T lymphocyte, there is an enzyme which maintains division of lymphocyte. That is calcineurin enzyme. Macrolides, they are calcineurin inhibitor. Because of this reason, T lymphocyte will not able to act, immunity will reduce, and Q for on heart, macrolides can cause QT prolongation. So this is the mnemonic, macro IQ. So now let's talk about few important points. First about this motilin receptor, then I will tell you about this calcineurin enzyme. So first is motilin receptor. Where do this motilin receptors are present? Can we say motilin receptors, they are present on muscles of GIT. Muscles of GIT. So this sphincter, which is made up of muscle, is pyloric sphincter. Because of this stimulation of motilin receptors, slowly and slowly the muscles becomes hypertrophied. That is why macrolides like erythromycin and clarithromycin are contraindicated in neonate because they can cause hypertrophic pyloric stenosis. But which macrolide is safe, which will have no risk of causing hypertrophic pyloric stenosis? That is azithromycin. Next point, which drugs must be avoided in neonate? So the first drug we discussed avoided in neonate was chloramphenicol. So chloramphenicol causes grey baby syndrome. That is why it was avoided in neonate. Sulfonamides. Sulfonamide, they are contraindicated in neonate because they produce kernicterus. Bilirubin enters into the brain of neonate, brain damage. Erythromycin and azithromycin, they produce hypertrophic pyloric stenosis. They must be avoided in neonate. But which drug is safe? Which drug does not cause? Not with azithromycin. Next point, a new macrolide, tacrolimus. Now, tacrolimus, it is not used as an antibiotic. No, it is not given to kill bacteria. Tacrolimus, it is rather a immunosuppressive drug. It is an immunosuppressant drug given to decrease immunity. And this tacrolimus, it is a calcineurin inhibitor. Because of this reason, at today's time, it has become the drug of choice for organ transplant people. Because in organ transplant, we have to reduce immunity of the body. One question comes, what is tacrolimus? You will answer, tacro, ACRO word is coming, macro, ACRO word is coming. Tacrolimus is a type of macrolide antibiotic. But its use is not like antibiotic. It is rather used as an immunosuppressive drug because it inhibits calcineurin enzyme. Now, there are two more drugs which will end with the word thromycin, but they are not macrolide, they are rather ketolide. The drugs are telithromycin, solithromycin. But don't worry, these drugs are not used because these drugs are highly hepatotoxic drugs, so they never entered into the market. Solithromycin never entered into the market, telithro also. But these drugs, just remember, thromycin word is coming, but they are ketolide group of antibiotic. Now let's talk about the treatment of certain infection. The first one we have is sexually transmitted disease. Two most important causes are gonorrhea, which is caused by Neisseria gonorrhea, and chlamydia, which causes lymphogranuloma venerum. Venerum means venereal disease or sexually transmitted disease. So what is the drug of choice for Neisseria gonorrhea? Remember, it's a community acquired infection, gram-negative bacteria. We give ceftriaxone. If ceftriaxone is given by injection, but sometimes in our country, we supply STD kits, and these kits are delivered to the homes by health workers. So at that time, we can give oral drug cefixime. Both are third generation cephalosporin. What about chlamydia? In chlamydia, we give doxycycline. The dose of ceftriaxone is 500 milligram intramuscular injection. Cefixime is also around 200 to 400 milligram. We don't have to remember the dose. Doxycycline 100 milligram for 5 days. Remember one point now, that ceftriaxone is a cephalosporin. Cephalosporin inhibits cell wall, and chlamydia does not contain cell wall. Hence, ceftriaxone or cefixime, they are not effective against chlamydia. Similarly, doxycycline. Doxycycline is also not effective against gonorrhea. That is why we add one drug. The drug we add, which is effective in both cases, is azithromycin. So azithromycin is effective in both cases. Now, what is the dose of azithromycin? For gonorrhea, we give 2 grams, single dose. And for chlamydia, we give 1 gram, single dose. So this is the treatment of all STDs. So if I'll ask you a question, that which drug is effective in gonococcal and non-gonococcal STDs, the single drug you can give is always and always azithromycin, effective in both cases. And if I'll ask you a question, there is a mixed infection. In that case, which dose of azithromycin will you give? 1 gram or 2 gram? If there is a mixed infection, sir, we will give 2 grams of the dose. Lastly, one additional point. Sometimes ceftriaxone, it can cause allergy because penicillin, cephalosporin, they cause lot of allergy. If there is ceftriaxone allergy, we can give one drug, replace this ceftriaxone with spectinomycin or gentamicin in cases of allergic reactions. Now, the next one is pertussis, Bordetella pertussis. So, 2 drugs are given for Bordetella pertussis. One is macrolide and second is cotrimoxazole. So, all macrolides can be given like erythromycin, as clarithromycin and azithromycin. But recently one question came, all drugs can be given, that if Bordetella pertussis occurs in 2-week-old neonate, this question came. In that case, remember, if neonate word is there, we don't give erythromycin, we don't give clarithromycin because first 2 drugs, they produce hypertrophic pyloric stenosis. Cotrimoxazole is also not given. It's a sulfonamide. It causes kernicterus. So if specifically mentioned pertussis in neonate, the only option you will have is azithromycin. No other drug must be given in neonate. Now let's talk about treatment of diphtheria caused by Corynebacterium diphtheriae. So the drug of choice for diphtheria is erythromycin or azithromycin. Another option which we can give is penicillin injections. We can give penicillins as well. But the most preferred drug is erythro and azithromycin. Now, if there is resistance cases, in resistant cases, we can give one drug for tuberculosis in diphtheria, that is rifampicin. We can give rifampicin in resistant cases. But in diphtheria, the main cause of death is not bacteria. We should kill bacteria by this antibiotic, but the main cause of death is diphtheria bacteria produces a toxin. This toxin spreads. That is why in emergency cases, we have to give antitoxin to neutralize diphtheria toxin. So this is the dose of diphtheria toxin. If the disease is less than 2 days old, we can give 20,000 to 40,000 units of antitoxin. If this diphtheria is limited to laryngeal area or pharyngeal area, but it is spreading to nasal area as well, nasopharyngeal, increase the dose from 40,000 to 60,000. And if this disease is becoming older, it's been more than 3 days, then increase the dose of toxin further, 80,000 to 1,20,000. So this is the treatment of diphtheria. Now let's talk about another important infection, that is prophylaxis of neonatal conjunctivitis. Now you must have heard about a disease, ophthalmia neonatorum. Now what is this? Just imagine a mother is delivering a child. When the child comes out of a mother, don't you think in mother genital tract there are bacteria? And those bacteria of mother genital tract can affect the eyes of this newborn baby. And infection in conjunctiva can happen. So that is why whenever a new child is born, for prevention of this eye infection, we put certain eye drops. This is known as prevention or prophylaxis of neonatal conjunctivitis, also known as ophthalmia neonatorum. 3 eye drops have been approved. The first is silver nitrate eye drops. Second is erythromycin eye drops. And lastly, we have tetracycline eye drops. For the prevention of neonatal conjunctivitis, the strength is 1%, 0.5% and 1%. So this is neonatal conjunctivitis. Now let's talk about fourth antibiotic, that is clindamycin. So clindamycin, it comes under a group known as lincosamide group. We don't have to remember the name, but remember there is a similar antibiotic just like clindamycin, that is lincomycin. So lincomycin and clindamycin are 2 antibiotics in this group. So let's see what was the mechanism of action of clindamycin. Same like macrolide, they also bind to 50S ribosome, and it also inhibits translocation of amino acid from A site to P site. Now, what are the uses of clindamycin? Very important. Remember a mnemonic TAP, TAP, TAP. First main use, clindamycin is given to reduce toxin production. Toxins are protein. To reduce or decrease toxin production, we give clindamycin in diseases like toxic shock syndrome. Second point with clindamycin is it is a very good drug for anaerobic bacteria. Anaerobic bacteria, very good drug, especially for one anaerobe, Prevotella. And second anaerobic bacteria is Propionibacterium acnes. Sir, I am writing a word acnes. Can you tell me this bacteria causes which disease? Yes, it causes acne. So we can give oral or topical creams of clindamycin for acne. And last, clindamycin is also a very effective drug for protozoan. For protozoan infection, we can give clindamycin like PMT. P for pneumocystis, malaria, and toxoplasma. Now, what is the main side effect? We discussed when we give clindamycin, clindamycin kills GIT bacteria. Clindamycin kills GIT bacteria. And when GIT bacteria is killed, one harmful bacteria can grow. Clindamycin carries the highest risk of causing Clostridium difficile bacteria infection in GIT. And this Clostridium difficile infection we discussed in previous section is known as pseudomembranous colitis. It can cause pseudomembranous colitis. Plus, clindamycin is also a hepatotoxic drug. So remember, pseudomembranous colitis risk is increased. Now let's make a summary of anaerobic bacteria. So for our ease, let's divide this anaerobic bacteria infection into two types. The first anaerobic infection which occur above diaphragm, can we call it as supradiaphragmatic infection? And the most common bacteria which causes supradiaphragmatic anaerobic infection is Prevotella. And below the diaphragm, which bacteria causes most of the anaerobic infection? That is bacteroids. So above diaphragm, Prevotella causes. Below diaphragm, bacteroids causes. So what is the drug of choice for the treatment of Prevotella? For Prevotella, we give clindamycin. So can we say clindamycin is given for supradiaphragmatic infections? What about infradiaphragmatic infection, bacteroid? For bacteroid, remember the drug of choice is metronidazole. We give metronidazole. Infradiaphragmatic infection. So after clindamycin, the next very important antibiotic is linezolid. Now linezolid, its group name is very big, very difficult to pronounce, oxazolidinol. But don't worry, you just have to identify. Don't you think linezolid, it is ending with the word zolid? And this group is also having some zolid word in it. Zolid word you have to identify. Similar to linezolid, now we have made two new antibiotic in this group. That is sutezolid and tedizolid. But what we have to remember with zolid? Linezolid. So sutezolid and tedizolid are new drug. What was the mechanism of action? Very unique mechanism of action. Linezolid binds to 23S subunit of 50S ribosome. And by binding to it, it inhibits initiation of protein synthesis. Why it was inhibiting initiation of protein synthesis? Because it was inhibiting attachment of methionine tRNA. And we know any protein, it starts synthesized with the help of methionine only. Now this linezolid is a very narrow spectrum drug. It is only given for gram-positive bacteria. And right now, it is only given in resistant cases of gram-positive bacteria. So let's write those gram-positive bacteria. Staphylococcus aureus, that is MRSA. Methicillin resistant Staphylococcus aureus. For this we made vancomycin. Vancomycin resistant Staph aureus, we can give linezolid. So VRSA, we give linezolid. But yes, it is also effective in MRSA. Second, after or similar to VRSA, we will write VRE. VRE stands for vancomycin resistant enterococcal infection. Staphylococcus VRSA, vancomycin resistant enterococci give linezolid. Lastly, linezolid, very important drug for gram-positive infection, MDR-TB. It is one of the very important drug for the treatment of multi-drug resistant TB. So all are gram-positive resistant bacteria. Now let's talk about certain good points with linezolid. Now linezolid, it is both an oral drug and it is an IV drug. And when linezolid is given orally, remember it has almost 100% oral bioavailability or oral absorption. Second point, linezolid great advantage is that linezolid is absolutely safe in renal disease patient. It is absolutely safe in renal disease. You don't have to reduce the dose of linezolid in renal disease patient. So let's talk about the side effect of linezolid. Remember a mnemonic COMB. C stands for chorioretinitis, or we can write optic neuritis. So can we say it can increase the risk of blindness? So with linezolid, monitor or just do regular eye checkups. Second very important MCQ, which antibiotic has action of MAO inhibiting enzyme? Which antibiotic is a MAO inhibitor? That is linezolid. MAO stands for monoamine oxidase enzyme. So because of this reason, remember MAO enzyme degrades various molecules in our body. All amine molecules are degraded by MAO enzyme, monoamine oxidase, like serotonin, histamine. If we combine this linezolid with antidepressant drugs like SSRI, they increase the levels of serotonin, and serotonin is degraded by MAO enzyme. So if we give linezolid with SSRI or antidepressant, the levels of serotonin will increase drastically. Because linezolid inhibits the degradation of serotonin, it can cause serotonin syndrome, especially when combined with antidepressant. And last side effect of linezolid can cause bone marrow suppression. In bone marrow suppression, what is very important is thrombocytopenia. Yes, it can also cause decrease in WBC, leukopenia. It also decreases RBC, anemia. But what is very important? Platelet count is reduced. Risk of bleeding increases. That is why if the patient is on linezolid, monitor platelet count with linezolid. If the patient is on linezolid. So that is why linezolid side effects we have discussed. We made two new drugs, sutezolid, tedizolid. Sutezolid and tedizolid, they are much more safer, less risk of bone marrow suppression. That is why we made it. Now let's talk about the second last antibiotic, that is streptogramin. Streptogramin, it is a mixture of two antibiotics, quinpristine with dalfopristin combination. So this combination is known as streptogramin. Question comes, in which ratio we combine? The combination ratio is 30:70. And this drug combination is an IV drug and it is a bactericidal combination. So it's a bactericidal drug. Just like linezolid, streptogramin is also a narrow spectrum drug, only effective against gram-positive resistant bacteria. So we will write, it is just like linezolid given for MRSA, but for MRSA drug of choice was vancomycin. So it is also effective in VRSA, but for VRSA we give linezolid. Streptogramin is even effective in LRSA. LRSA is linezolid resistant Staphylococcus aureus. Now this streptogramin, its main side effect is myalgia, muscle pain, arthralgia, joint pain. It causes myalgia and arthralgia. So this is streptogramin. So now let's talk about the last group of drug in protein synthesis inhibitor, very important, aminoglycosides. So recall what was the mechanism of action of aminoglycoside. They bind to 30S subunit of ribosome. And they have multiple actions. They have IMP3 actions, important. They inhibit initiation of protein synthesis. They produce misreading of mRNA. and they inhibit polysome formation. Polysome was assembly of ribosome with mRNA. So which other drug I have told you was inhibiting initiation of protein synthesis? That was linezolid. So linezolid and aminoglycoside, two antibiotic inhibiting protein synthesis. Now what is the cause of resistance? Resistance is again because of enzymatic inactivation. That means when this aminoglycoside enters into the bacteria, bacteria produce certain enzymes which inactivate them. So those three enzymes are AAT, that is aminoglycoside acetyltransferase enzyme, APT, aminoglycoside phosphoryltransferase enzyme, and ANT, that is aminoglycoside nucleotide transferase enzyme. So sometimes nucleotides like adenosine will attach to them and they will become inactive. But there are two aminoglycoside against which resistance is uncommon. Resistance is uncommon against amikacin, which is an aminoglycoside, and plazomicin. So if I will ask you this question in indirect way, which is the most effective aminoglycoside against a bacteria? You will get an option of amikacin. Can we say that they are the most effective aminoglycoside for any bacteria? Now next point is that aminoglycosides, they are highly polar molecule. Highly polar means they are highly ionic. Ionic means water soluble. And we know that any drug which is a water soluble drug cannot cross a cell membrane. So can you give oral aminoglycoside? And if you give oral, will it get absorbed from GIT? The answer is no. Remember, aminoglycosides when given orally, they are not absorbed from GIT. So that is why for any systemic or body infection, we have to give injections of aminoglycoside. And we know any drug which is already a water soluble drug is not metabolized in liver. Not metabolized in liver means liver converts lipid soluble drug into water soluble form. Aminoglycosides are already water soluble, so they don't need to go into the liver. They are simply excreted unchanged. Unchanged means without any metabolism in liver. They are excreted unchanged in urine by kidney. Now in kidney they get simply filtered and are excreted in urine by glomerular filtration. So here comes one very important question. Can we give aminoglycoside in liver disease? So the great advantage of aminoglycosides are that they are safe in liver disease patient. No problem occurs. But the problem occurs in kidney. So aminoglycosides, remember, they require dose reduction in renal failure patient, and they also require dose reduction in old age patient, because in renal failure and old age, with age, there is reduced glomerular filtration rate. So GFR reduces in renal failure and old age. Hence aminoglycoside will accumulate in the body and their toxicity can come. But what is the contraindication? Aminoglycosides are absolutely contraindicated in pregnancy, because in pregnancy they can cause fetal ototoxicity. And ototoxicity, we will also discuss, is a very important and dangerous side effect of aminoglycoside. Permanent deafness can happen. So next few important point is aminoglycoside, they are narrow spectrum drug. Narrow means that they are only effective in aerobic bacteria. Aerobic bacteria means those bacteria which utilize oxygen. The reason is very important that aerobic bacteria, they contain some oxygen dependent porin channel. When we give aminoglycoside enters into the bacteria with the help of oxygen dependent porin channel, which is only present in aerobic bacteria. Do you think this channel will be present in anaerobic bacteria? The answer is no. That is why aminoglycosides, they are not effective in anaerobic bacteria. So keeping this thing in mind, let's talk about 4 bacteria against which any aminoglycoside is not effective. They are inherently resistant. Remember a mnemonic? BATA. B for Burkholderia. Aminoglycosides are not effective in Burkholderia. They are also not effective in anaerobic bacteria, anaerobes. They are not effective in typhoid, Salmonella typhi. So question comes, can we give amikacin for typhoid? You will say, sir, no, it is inherently resistant. And lastly, one hospital-acquired infection occurring in ventilator patient, Acinetobacter baumannii. The reason for resistance is that these bacteria don't have porin channel. No porin channel is there. Aminoglycoside cannot enter into these 4 BATA bacteria. Hence, we don't give. So now let's talk about what are the drugs we have in aminoglycoside. How to identify. Remember, they will either end with the word omycin, like streptomycin, paromomycin. Mycin word will come, gentamicin. And lastly, casin word will come, like amikacin, etc. So why they are named different? Because they are obtained from different species of bacteria. So if a bacteria is, let's say, Micromonospora, mycin word we put. If streptomyces bacteria we obtain, we write omycin word. So that point is irrelevant. But just remember omycin, mycin or casin word will come. So let's talk about first very important drug, the oldest one, streptomycin. So streptomycin and these drugs, they are either given intravenously or intramuscularly because they are not absorbed orally. Streptomycin, it is the drug of choice for plague treatment. And we discussed for prevention of plague, we were giving doxycycline. It is also the drug of choice for tularemia infection caused by Francisella tularensis. Now, first 4 aminoglycoside we will encircle. That is streptomycin, amikacin, capreomycin and kanamycin. Let's make a short form SAC. Strepto, amikacin, capreomycin, kanamycin. These SAC aminoglycosides, they are given in the treatment of tuberculosis. So these 4 aminoglycosides SAC, TB. Now let's make another group. Gentamicin, again amikacin and tobramycin. Let's make a mnemonic GAT. Gentamicin, amikacin and tobramycin. They are given for the treatment of Pseudomonas infection. Now Pseudomonas, sometimes it can cause pneumonia, especially in a person who is suffering from cystic fibrosis. And if a patient is on ventilator, for this pneumonia Pseudomonas, what we can give? We have made special aerosols of these aminoglycosides. So aerosols of tobramycin, amikacin is available if there is Pseudomonas pneumonia. Similarly, Pseudomonas sometimes in immunocompromised people can cause corneal ulcer also. For this corneal ulcer, we have eye drops of tobramycin. Tobramycin eye drops are also present. The concentration of tobramycin eye drop is 0.3%. Then we made a new arbicacin. Arbicacin, it is approved for the treatment of MRSA infection, methicillin resistant Staph aureus. And the last drug we have is paromomycin. Paromomycin, it is given for the treatment of protozoan infection. Paromomycin, protozoans like Kala Azar. Kala Azar is caused by a protozoa Leishmania. It is also given for amoebicidal drug, amoebiasis, which is caused by a protozoa that is Entamoeba histolytica. So now let's talk about one very important technique or thing which we do in our hospital. These aminoglycosides are usually combined with any of the cell wall inhibitor. So when we combine aminoglycoside with cell wall inhibitor, they have additive effect. Additive effect means they show synergism. Their activity increases. The reason is very simple. Sir, if we give cell wall inhibitor, can we say now if the cell wall is inhibited, aminoglycoside can now easily enter into the bacteria and now it can easily inhibit protein synthesis. So let's see certain combination which is very effective. So the first cell wall inhibitor penicillin drug is ampicillin. Ampicillin is combined with one aminoglycoside gentamicin, and this combination is the drug of choice for one serious infection, Listeria infection. Listeria meningitis, give ampicillin with gentamicin. Similarly, another cell wall inhibitor, cephalosporin, is ceftazidime, combined with gentamicin. This combination is the drug of choice for Pseudomonas infection. They are given by injection, Pseudomonas systemic infection. Lastly, another cell wall inhibitor is vancomycin. So vancomycin is combined again with gentamicin. So can we say gentamicin is the most commonly combined aminoglycoside? Or we can combine with tobramycin, and this combination is the drug of choice for enterococcal endocarditis. So these are the combination of aminoglycoside with cell wall inhibitor. Now we have aerosols. Aerosols, beta, we already discussed. We can give aerosols of amikacin. We can give aerosols of tobramycin, especially if the patient is having Pseudomonas pneumonia. So for those Pseudomonas pneumonia, we can give aerosols of inhaled aminoglycoside. Any other drug? Yes. In aminoglycoside resistant cases, we can give another drug, colistin. Colistin aerosols can also be given for the treatment of Pseudomonas pneumonia. Then we have oral aminoglycoside. In oral, we will write a very important drug, oral neomycin. Before writing the use of oral neomycin, just recall, do you think neomycin when given orally, will it get absorbed from GIT? Remember, it is not absorbed from GIT. So, if it is not getting absorbed from GIT, don't you think this neomycin, but still, it will kill normal GIT bacteria? So, it is given for killing normal GIT bacteria, which is known as gut sterilization. When we want to kill the normal GIT bacteria and we do gut sterilization in the treatment of hepatic encephalopathy. So what was this hepatic encephalopathy? We discussed in GIT in great detail. I'll tell you again. Remember, hepatic encephalopathy occurs when there is liver damage, cirrhosis happen. When cirrhosis happen, can we say ammonia, which is a toxic molecule, will not be converted into urea? Bilkul. So if ammonia will not be converted into urea, ammonia level increases and this ammonia can damage brain. So don't you think we have to reduce ammonia production? GIT bacteria in our body, they produce ammonia, and in liver damage, we have to kill GIT bacteria. There are 3 drugs which are approved for hepatic encephalopathy. The first drug is lactulose. So lactulose syrups which is a laxative drug discussed in GIT, reduce ammonia absorption. We give oral neomycin to kill GIT bacteria, and the third oral antibiotic to kill GIT bacteria is rifaximin. Overall, the most effective drug and drug of choice is rifaximin for hepatic encephalopathy. Lastly, topical creams of aminoglycoside. The first topical aminoglycoside given as skin cream is Fremycetin. And this Fremycetin comes with the brand name Soframycin. So you must have heard about Soframycin word. How to identify Soframycin? Fremy word is coming. Fremycetin, Fremy word is coming. So Soframycin contains Fremycetin. Another skin cream of neomycin. It comes with a brand name Neosporin cream. So aminoglycosides given as a skin cream. Now let's talk about very important adverse effect of aminoglycoside. The classical 3 adverse effects of aminoglycosides are: they damage ear, ototoxic; they damage kidney, nephrotoxic; and they produce neuromuscular blockage. So in ototoxicity, remember, aminoglycosides, they damage hair cells of ear. Remember, hair cells are neurons which are floating in endolymph. My question is, if hair cells become damaged or neurons will become damaged, will they regenerate? The answer is no. Neurons cannot regenerate. So this ear damage is permanent. So it is a permanent ear damage. What about nephrotoxicity? They damage renal tubular cells. Now, renal tubular cells, remember, they can regenerate. So do you think nephrotoxicity is irreversible or permanent? No, sir. It is reversible. So what is more dangerous? More dangerous is ototoxicity. Now what happens in ototoxicity and nephrotoxicity? They can produce vestibule damage. So if vestibule cells becomes damaged, they can lead to nystagmus, diplopia, ataxia, because the function of vestibule is to maintain balance. But if cochlea becomes damaged, don't you think they can lead to hearing loss? Aminoglycoside, they can lead to high frequency hearing loss. So high frequency hearing loss means when I will say something very subtle in very low voice, you will not able to hear me. That is why most of the time the patient will not seek a doctor, because less amplitude or less frequency voice are not heard. What about nephrotoxicity? Renal tubular cells are responsible for absorption of ions. Because of this reason, there is loss of calcium, magnesium, potassium in urine. Now, what about neuromuscular blockage? So, if we see the structure of a neuron, and this is a muscle, we all know that neurons, they release acetylcholine, ACH. And this acetylcholine acts on one receptor on muscles known as NM receptor. When NM, nicotinic muscular receptor of acetylcholine, it causes contraction of muscles. Now, aminoglycoside, remember, they inhibit the release of acetylcholine, plus they block NM receptor. So how they cause neuromuscular blockage? They inhibit acetylcholine release, and they also block NM receptor on muscle. Because of this reason, the patient will suffer from muscle paralysis or muscle weakness. Now, can you recall any disease in which antibodies, they block NM receptor? Yes, that autoimmune disease is myasthenia gravis. So in myasthenia gravis, already NM receptors are blocked. Don't you think if you give aminoglycoside, it will aggravate this condition? That is why aminoglycosides are absolutely contraindicated in autoimmune disease known as myasthenia gravis. So one question comes, sir, if there is ototoxicity, nephrotoxicity, what is the antidote? The one common antidote for any toxicity for aminoglycoside is give calcium. So we give calcium gluconate as an antidote for aminoglycoside for ototoxicity, nephrotoxicity and neuromuscular blockage. So which aminoglycoside is most toxic? Maximum. So maximum cochleotoxic and maximum vestibulotoxic. Maximum cochleotoxic, we can remember a mnemonic CAN. That is kanamycin, amikacin and neomycin. Neomycin overall is maximum. Vestibulotoxic, streptomycin. So how we can remember? All these aminoglycosides were given in tuberculosis. Now remember, if a question comes neomycin, which is the most toxic, neomycin, because of toxicity, we never give by injection. So the next most toxic will become amikacin. While least toxic overall for all of them is netelimycin. Netelimycin, it is least cochleotoxic and least vestibulotoxic. Most nephrotoxic, again we will write neomycin. But neomycin, because of toxicity, is never given by injection. So the next most toxic will be gentamicin. While least nephrotoxic is streptomycin. Lastly, neuromuscular blockage. Again, maximum is by neomycin, but we don't give neomycin by injection. Then the most neuromuscular blockage is by streptomycin. But the safest one is tobramycin. Safest one is, least risk is with tobramycin. So from this part, we have understood one concept. The overall most toxic aminoglycoside is neomycin everywhere. That is why we rarely use neomycin as an injection. So the last slide is, let's make a list of the drugs which are effective for Pseudomonas. So Pseudomonas is a gram-negative infection. So we give all beta-lactams. There are 4 drugs in beta-lactam. That is penicillin, cephalosporin, carbapenem and aztreonam. Remember, in cephalosporin, only 3 from 3rd generation, all 4th generation and all 5th generation cephalosporins are effective against Pseudomonas. In 3rd generation, I have given you a trick. Identify the word Z. Z word will come like ceftazidime, cefoperazone, ceftolozane. If you can write, just write one more one, moxalactam. In 4th generation, I have told you to identify pi word. 5th generation cephalosporin, identify rol word like cefepime, cefepirome. And 5th generation are ceftaroline, ceftabiprole. Now after 5th generation, which penicillins we have discussed were effective against Pseudomonas? Only CT-MAP. CT was carbanicillin and ticarcillin and MAP was meslocillin, azlocillin, P for piperacillin. Now carbapenem, any drug, it will end with the word penem like imipenem, meropenem. So they are given in resistant cases, and in carbapenem resistant cases, we give colistin. Aztreonam, one more beta-lactam which can be given in allergic cases of above drug. Aminoglycoside, we discussed 3 aminoglycosides effective against Pseudomonas: gentamicin, amikacin and tobramycin. Lastly, fluoroquinolone like ciprofloxacin. Now the question comes, among this whole list, which is the only oral drug for Pseudomonas? The only oral drug we have for Pseudomonas is ciprofloxacin. So this is a list, just we will write for reference. Now let's make a summary now. So which drugs among protein synthesis inhibitor act on 30S subunit of ribosome? We discuss only 3: ATT, aminoglycoside, tetracycline, and its big brother tigecycline. Rest all other protein synthesis inhibitor, they act on 50S ribosome. Now among this big list which we discussed, only 2 drugs were bactericidal, A and S. Rest all other were bacteriostatic, aminoglycoside and streptogramin. Now Gray baby syndrome and aplastic anemia is caused by which drug? Chloramphenicol. Now, which drug is given for cholera, chlamydia, leptosporiosis and borrelia? That was doxycycline. Now, which tetracycline was safe in renal disease patient? That was doxycycline. Now, expired tetracycline in a patient can cause Fanconi syndrome, in which there is damage of PCT, proximal convoluted tubules of nephron. Now, tooth damage in children is caused by which group of antibiotic? Tetracycline. Because tetracycline, they chelate with calcium. Calcium is present in tooth. Resistance in tetracycline and tigecycline occurred in a bacteria because of efflux out of a bacteria. Bacteria throw them outside. Hypertrophic pyloric stenosis in a newborn is caused by which 2 antibiotic? Erythromycin and its brother clarithromycin. And we discussed it was not caused by azithromycin. What was the drug of choice for chancroid, legionella, pertussis and diphtheria? Same, macrolides like erythromycin, azithromycin, etc. Tacrolimus is a calcineurin inhibitor. And calcineurin enzyme, we discussed, it's present in T cells, T lymphocyte. So it's a type of a macrolide antibiotic, tacromacro, and it is used as an immunosuppressive drug for the treatment in organ transplant people. Clindamycin increased the risk of which Clostridium infection? Clostridium difficile infection, which causes a disease, pseudomembranous colitis. So linezolid, it acts by very unique mechanism of action. It binds to 23S subunit of 50S. And binding to this 23S subunit, it inhibits initiation of protein synthesis. Which drug inhibits MAO enzyme, monoamine oxidase enzyme, causes optic neuritis, and in bone marrow suppression, it causes thrombocytopenia. We discussed a mnemonic COMB. That was linezolid. Aminoglycosides, they are excreted through urine by glomerular filtration. That is why aminoglycosides, they require dose reduction in a patient of renal failure and old age, because with age, GFR reduces. Streptomycin, amikacin, capreomycin, kanamycin, 4 aminoglycoside, short form was SAC. They are given for the treatment of tuberculosis, TB. Oral neomycin, if you remember gut sterilization, it kills GIT bacteria. It was given for the treatment of hepatic encephalopathy to reduce ammonia production from GIT bacteria. So what were the toxic effect of aminoglycosides? Sir, 3 toxic effects: ototoxic, nephrotoxic, and neuromuscular blockage. Because of neuromuscular blockage, aminoglycosides were not given in myasthenia gravis. So let's solve certain MCQs. So chloramphenicol causes which side effect? We will write Gray baby syndrome is a side effect of chloramphenicol. That is why not given in neonates. Doxycycline. Doxycycline is a tetracycline. Tetracycline causes tooth damage. Now, erythromycin, especially in neonate, causes hypertrophic pyloric stenosis. Some motilin receptors were getting stimulated, and linezolid causes thrombocytopenia. Next question. A 45-year-old man is prescribed antibiotics for endocarditis secondary to streptococcus. The drug lacks intrinsic activity against anaerobe. The drug is not effective against anaerobic bacteria, and its resistance occurs because of enzymatic drug inactivation. So that drugs were aminoglycoside. Aminoglycoside needs porin channel to enter into the bacteria, and it was given in endocarditis along with vancomycin drugs, and resistance occur because of enzymatic inactivation. So what is a false statement about tigecycline? Tigecycline, remember, a new drug just like tetracycline. It binds to 30S ribosome and inhibit protein synthesis. True. It is effective in MRSA. Yes, we discussed 3 uses of tigecycline MAD. MRSA, abdominal infection, dermis or skin infection. It is safe in renal disease patient. True. We discussed 3R with tigecycline, renal safe, reserve drug, resistance is uncommon but developing. So resistance is widespread. Now this is a false statement. It's a reserve drug. Yes, the resistance occurs because of efflux transporter, but it is not widespread. That is why it is a reserve drug for hospital-acquired infection. A female patient presented with vaginal discharge. Which antibiotic can kill both chlamydia as well as gonorrhea? So that drug was azithromycin. So we discussed that in gonorrhea we gave ceftriaxone with azithromycin, while in chlamydia we gave doxycycline with azithromycin. So common drug for both chlamydia and gonorrhea was azithromycin. So this finishes our protein synthesis inhibitor. Best wishes. Thank you very much.